Hi, welcome to My Favorite Mistake. I'm Mark Graven. Our guest today is Dr. Derek Leiner. He trained in internal medicine at VCUHealth in the Richmond VA Medical Center. In 2018, Derek completed a year as chief resident for quality and safety, a national VA QI and safety training program, then began as a staff physician at the Richmond VA Medical Center. So before I tell you a little more, Derek, welcome to the podcast. How are you?
Thank you very much for having me. I'm doing great. Really excited to be here.
Well, great. It's good to have you here. I'm sure there's no shortage of jokes about the double meaning of Richmond VA. It's the Richmond VA in Richmond, Virginia.
Yeah, all the time.
So I knew that wasn't like a uniquely clever thing for me to point out. I couldn't help it. But we have more serious topics to discuss here today, but a little bit more about Derek. His career has included teaching, education leadership as an associate program director for a medicine training program and in safety culture leadership. He currently works as an academic hospitalist and is the physician champion for high reliability at the Richmond VA Medical Center. And we'll be able to talk about some of those topics and more later in the episode. But so I look forward to that discussion. But, as we always do here, Derek, as you know, the key question I like to ask and start off with, what would you say is your favorite mistake?
Well, thanks again for having me. And it's I wish I could say there are only few, but we are human and we do make mistakes. I wanted to share a story of a time on clinical medicine. I was just coming on to a rotation as an attending. The team also had new interns starting that same day, so a lot of new faces on that case. We were starting that week with a very heavy patient load, a lot of patients. We were actually over what is usually a cap for our team, and that was just sort of the way the admitting structures sort of worked. So there's a lot of things going on, a lot of complex illness, a lot of challenging situations with a couple of kind of hard conversations to have with families. And so it was just painting the picture of a chaotic day. There was a young gentleman who was on that service. He had a worsening neurologic injury. And we didn't really know why that was happening. And part of that workup was going to be doing something called a lumbar puncture, where we go into that spinal space and remove some of the fluid and send that off for some testing. And it got to be the afternoon when we were planning to do that procedure. We, the way that this had worked at the hospital where I was at the time, it was that the inpatient team would need to ask for, or would need to try first before kind of a more experienced operator would step in and help. And so we were going to do the procedure at bedside. As we were preparing and getting our materials, at that time, something came up. The resident I was with said, "Hey, you know what? I'm going to really take care of this discharge situation. Is that okay that you do the lumbar puncture with the interns?" I thought that was completely fine. So we went to bedside. We do something called a timeout, which is just a checklist of things to make sure that the patients are going to be safe for the procedure. The patients know what's going on. They've consented for the procedure. They know the risks. In that, we look at making sure that no one's on a blood thinner, because a procedure on a blood thinner, especially going into the spinal space, can be dangerous. And so I looked down at this handoff tool that we use, looked at the patient's medications. The blood thinners were not on that list, and so we proceeded to do the procedure. This patient was a larger gentleman. He also, because of his neurologic injury, had some spasticities. He was trying to lay down, a lot of pain. And so it made the procedure just technically difficult. And unfortunately, we were unsuccessful in getting into the spinal space. So we were going to bring the needle out and talk with our experts for some help. And as the intern removed the needle, all of a sudden, a lot of blood is coming out of this gentleman's back. And so I jump in right away, hold pressure, trying just like rapidly to think of what could have just happened. I was reviewing the anatomy again in my brain, just trying to think of what is happening, what did we hit. And fortunately, the bleeding was very quickly controlled. The vital signs were completely fine. The patient had no additional pain. Everything ultimately was okay, but there was that moment there that was very worrisome.
Right.
Ultimately, about an hour or two later, I get a text message from a resident, "I need to talk to you." And I knew as soon as I got that message from her what the problem was going to be. And we found out that the patient actually did receive a blood thinner that morning. Enoxaparin is a very typical medication that we use for patients who are hospitalized to prevent blood clots that people can get when you're stuck in a hospital bed for several days. There is a warning with that medication that this should not be done with procedures. And it's controversial for spinal procedures, but really my practice is always to make sure no one's gotten it before we do a procedure going into the PAC. And unfortunately, that was something that we had missed. Went back, disclosed to the patient, let him know what was going on, and told him what the steps were going to be to try to move forward with it. But that's something that still weighs on me, that we had done that procedure with that blood, when he had received that blood thinner.
Yeah. Was when you say there was a miss, that it hadn't been charted, or it was missed in reviewing the chart before the procedure?
So what I had used in my when I was at bedside doing the sign out was that written list of medications. It is a tool that we use, and there is some potential error with that tool because it requires someone to be putting that information in every day. When we looked back and tried to investigate what happened with this event, we realized that the team over the weekend had thought the patient was off the medication. The patient was off the medication, but as someone was finishing up some work late Sunday evening before our new team took over, it was like 8 or 9 o'clock, they went ahead and threw that enoxaparin back in on the patient because it's a quality measure that we are tracked on. That we want to make sure that people who are hospitalized do have those prophylaxis blood thinners, and so this person threw that in there, and that was just unbeknownst to the team, so it wasn't added to the medication list before rounds, and so the tool that we were using, the list that we had, was wrong for that reason.
Right. So would you consider this a quote unquote near miss or a patient harm? I mean, you said you stopped the bleeding, everything was okay. Either way, it's a learning opportunity. So maybe that, I don't know, does that designation even matter, even informally, near miss versus harm?
Well, I think the designation matters. And there are, unfortunately, a couple of different definitions. But the ones that I like are that if this is a unsafe situation, or there was the potential for a patient being harmed, and something stopped that event from happening, that would be a near miss. Or dumb luck prevented the patient from getting hurt. That's still a near miss. If someone actually does, have harm, and it can be that something was intended and it was missed, or something was done when it shouldn't have been done, those I consider those to be harm events, and those have a different levels of severity as well. So, but I'm sorry. The only thing that I was just going to say was that my hope when we investigate events is that we take it seriously no matter what. Often, I think often we sometimes falsely believe, the person didn't get hurt, I'm so glad. When actually, if we do the work to understand why even a near miss or a close call happened, it can be a canary in the coal mine sometimes. It can be a clue to something much deeper that is a larger threat to an organization or to a team. And so I think the work is, the work of investigating that is needed no matter the severity.
So do I have it right by what you shared about a near miss? If you were about to do the procedure and somebody came running over at the very last minute and said, "Dr. Leiner, wait, they're on a blood thinner," that might be more in that near miss category. Okay.
And when we talk with teams, or when I teach residents about safety culture and our duty to report and what that means for making our healthcare system safer, either one should have been reported and investigated. So even if someone runs into that room and says, hey, this is something we need to stop, we still need to explore why it was that we were using a tool at bedside that was inaccurate.
Right. So what do you remember about the reaction and the response to that? I'll use the word incident. I don't mean that in a judgmental or blaming way, but just as a different with the event. What do you remember about the response. And what I'm hoping is, it would be more focused on understanding and learning than, a sort of, punitive blame game. What do you recall then in terms of what happened afterwards?
One of the reasons I like, as it's weird to say it this way, but one of the reasons that this is a favorite mistake is because of the opportunity to help the team afterward. And so personally, my response was one of intense guilt. I mean, my stomach sank. I felt lightheaded. I felt nauseous. I remember going back to the room to disclose with the patient and how shaky I felt. How embarrassing that was when we are trying so hard to provide a transformative healing experience, to take great care and safe care of patients. When something like this happens, I feel like I just didn't live up to my goal and my duty as a physician. And then as we were debriefing the event, just in the team room, kind of talking about what had happened, I saw this, I could see it, like the body language was clear that everyone felt the exact same way. And in part of my education work, I developed some curricula around how do you work through error. And I've had practice and myself working through error. And so that was an opportunity for me to actually use some of those tools with that team. Some of the members of the team had just become senior leaders or senior residents, and so it was a great chance to be able to teach how to work through that. That's kind of more like the team involved response. And then of course we want to make sure that we report what happened so that we can investigate it. And then there is an organizational response in that investigation. And I'm happy to say that it felt non-punitive. All of the conversations were, what could have happened? We know this was not something you meant to do. What were the system pieces that played a role? And that led to those much more fruitful conversations of, okay, here are the things that we can change so that when humans interact with systems, we aren't relying on a system that is inaccurate. For example, like the conversations around how do we build a handoff tool that maybe has more accurate information on it.
Right. And I mean, the one thing that stood out to me, correct me if I'm wrong, you talked about a handwritten or a written, or was it a printed list of medications? I'm trying to think, like, how did that not get updated? That would be worth digging into, right? Not Absolutely. Who didn't update it, but
Right, absolutely. It's a Word document, and so it's printed each morning. It's usually updated at the end of the shift every day before we hand off to a night set of physicians. And so when a medication had changed in the middle of the night prior, that wouldn't have been captured until the next day. And that's exactly what system piece we've been so passionate since then about, fixing is, we need to figure out a way that maybe we have some sort of software that pulls that information from the chart and doesn't rely on a human to remember to update it.
Right. Because when you say, relying on a human to remember it, we're human. We forget. We get distracted. We're under time pressures. There's systemic factors. And, when you say something, well, it usually gets updated. Like, to me, one outcome of having a high reliability organization would be the usuallys become an always. So there's jargon and terminology that the listener might not know. Could you talk a little bit about, briefly, this concept of high reliability organizations and what that means in healthcare in terms of, preventing and learning from mistakes?
Yeah, absolutely. I think a lot of the conversation around safety in healthcare started in the late 90s with a report that came from the Institute of Medicine called To Err is Human. And they estimated in that report that it was up to 100,000 people were dying in American hospitals because of human error. And it's been studied over and over again since then, and it's hard to say what the exact number may be. And you can don't need to get into some of the controversial numbers of that, but I think we can't argue with the fact that error happens, mistakes are happening, and it has patient consequences. And so we rally around this. We embrace this idea that we must make healthcare safer. though I think we've embraced that well, the progress in that aim has been slow. It's been 25 years, and we're still not seeing, the minuscule accident rates that we see in aviation or naval operations or nuclear power. Like we aren't matching that, and we have to figure out why. And I think that trying to understand that why led to a investigation to how those other safer systems work. And that led to this idea of high reliability. And so you can find several different definitions of this also. The one that I like is that high reliability organizations, or HROs, are those complex organizations that have fewer than their fair share of accidents despite their complexity. And healthcare certainly is that. It's a system of microsystems, and we have to move a patient through all of those different microsystems to provide complete care. And so, how do we do that without hurting people? Has been, has been a big question.
Yeah,
I think when you hear that definition, sometimes you think of HRO as an entity, and what I like to teach and remind folks is HRO is, for me, a mindset. It's a combination of the collective behaviors and collective beliefs and the culture of that organization that drives our goal to have zero harm.
Right.
So there's a series of behaviors and values and beliefs that we try to teach and adopt, so that we are always thinking about where error may be, and it's recognizing and where threats may be coming, situational awareness, being safe with each other to speak up when things don't feel right, trusting each other when someone says something isn't right, celebrating speaking up behaviors, like all of these things that tie into a shared mental model of what threats are coming at a team, or what threats are coming toward a patient, so we can stop it before it happens.
Yeah. Yeah. And in this case, one other question I wanted to ask was, what do you remember about the patient's reaction to this being disclosed?
I was so glad that he gave us so much grace. I remember when we were learning about disclosing bad news or disclosing error through medical school or residency training, that a lot of the teachers or the educators would talk about. A lot of times the patients understand, and what we really need to be do. And when we're one human taking care of another, is being honest and being transparent, and not trying to hide it, and certainly not taking it lightly. And so we try to be very honest, like, this is something that we take very seriously. We want you to have the best care. This should not have happened, and we feel so terribly about it. And we feel so sorry. And I always like to remind them that I promise them that it will be reported, and I follow through on that promise. And we are going to figure out the system pieces that played a role here, and we're going to look for why this happened, outside of the human mistake. What's the system piece that played a role? And so we told that to him. We told him, like, this is what happened, and he was so kind. He was, hey, I get it. You have been here before. This is the fourth time I've been admitted. You guys have been helping me. So I know mistakes happen, and it's no problem. And, thank you for reporting it. And, interestingly, that made it feel worse. I don't know why,
his reaction did, you mean?
Yeah.
Or
It's just like,
oh, well.
you try so hard, and then they're so understanding. It's just like, I'm so glad to be taking care of you. And I don't know. It just sort of, I don't know why it made it feel worse. It just, like, it's almost like an unexpected response. Like, I feel like I would be angry if that happened to me. And to see someone give us so much grace, it just, it felt so good. And that was really nice.
And your story and what happened there is kind of an interesting contrast. I forget, did I point you back when we had talked before to episode 70 of the podcast with Dr. David Mayer? So, what had happened there, quick synopsis. And David was kind enough to kind of follow up with me and flesh out some other details. That story is also in my book. But what Dr. Mayer was describing, he was a resident anesthesiologist. So there was, I guess, a couple of decades earlier, there was kind of multiple pecking orders of resident to attending. anesthesiologist to surgeon. Like, to me as a patient, I want everyone to be a team. I don't want there to be a pecking order. But, there was a wrong side incision made, and the story Dr. Mayer recounted was basically the attending surgeon lying to the patient and saying, you got 2 procedures for the price of one. And the patient was happy and thankful. And Dr. Mayer regretted not speaking up. But, I even in the moment tried to, see the episode, tried to console him a bit of like, well, please don't beat yourself up, because, there's this culture factor where he predicted, probably correctly, he would have gotten in trouble for speaking up and for not going along with the lie. And his medical education did not address what you're touching on, of how to share something with a patient as comfortable as it might be. So, I think there's some different standards or expectations over time. I'm curious your reaction to what you remember of Dr. Mayer's story. I'm glad you had a situation where there could be that candor and that more constructive follow-up.
Yeah, I remember that story. I found it striking, and it made me reflect on my experiences and, thinking about how hard it is to disclose something to a patient. And I think that there's always the concern that they've put their life in your hands, and if you've made a mistake, that there's going to be sort of litigation or tort or things like that. And I find that that may lead people to want to hide things. I think that a lot of the reports from IOM from the 1999 and others, and the conversation around healthcare becoming safer in our country, I think has led to more of those curriculums focusing on honesty, transparency, humanism, collaboration, and disclosing error. And so I was glad to benefit from that in my education, to have some of those tools in my toolbox to talk with that patient.
Yeah. Yeah, I mean, it's said, I think there are studies, this is not my expertise, but what I've heard colloquially is patients sue less often when there's a disclosure and a sincere apology. And I know some people that I've run across in patient safety circles, their child was harmed or even killed. And there's medical error, and part of any there's grief, there's sadness, there's all kinds of emotions, but then there's a level of anger when they feel like they're being stonewalled, they're not getting answers, and then sometimes it seems like legal action is as much about getting answers than it is wanting to punish anybody.
Yeah. I don't know. I've heard the same thing, but I don't know the data behind it either. And when I think about whether I'm working with the patient directly when I'm on a non-teaching service, or when I'm working with house staff, trainees, and trying to model physicianship for them and teach them physicianship, ultimately, my hope is that I can really help the patient understand that I see them as a human and not someone who's sick, or only sick, or someone who's only got a disease or only a primary problem to manage while they're inside the hospital. And so I've been trying, and this is a more recent development, to be honest, but I've been trying to be much more brave and much more gracious when someone is asking for talking with my supervisor, or talking with a patient advocate, or if my care gets reviewed by a peer under something called a peer review process, if they're worried that I made a mistake or did something that's not standard. And those things are rare, fortunately, but I'm trying to practice seeing the value in all those things. And so if someone does want to move toward litigation because they don't feel like they're giving the answers, I try my best to be honest, but I try to support them. Like, I do want them to have the best experience, and I want to hear the feedback to how we grow, because there's going to be things that they're experts in their care, they're experts in their body, there are things that they know that we need to learn so that we can take the best care of them. And so if going through a lawyer or talking with the patient advocacy or the patient experience center is the way to do that, I really want to try to support that, even though it can feel really hard for what that might mean for me in terms of, punishment or discipline or things down the road.
Yeah. Because I mean, I'd like to think if I was in that situation, if I were harmed by a mistake, I would want the event, the incident to be reported would be my focus, not the person being reported. Like we hear that word reported, and different people might jump to different conclusions. But I think of even like completely unharmful and benign customer service mistakes.
Mm-hmm.
I hesitate sometimes to point it out or complain to a company because I'm worried that somebody might get blamed or punished for something that's really a systemic problem. Like I have probably a higher sensitivity to that than most. I'm not saying I never complain, but there's times where I really do think that sadly sometimes the default is a response of, and I learned this phrase in healthcare: naming, blaming, and shaming.
Mm-hmm.
Like sometimes they'll say, it's not worth bringing it up because so and so was doing their best, and it was human error or probably some systemic cause, and I'll say, I'm gonna just let it go. I don't.
Yeah.
It's organization. It comes back to organizational culture or human dynamics or things that are pretty common.
Yeah, I agree, and it reminds me of that concept of just culture, or the just culture response to error. And there are times where, and learning about this has actually changed the way that I watch processes. Like I'm going through a drive-through or something, and they get orders mixed up. It's like that they're doing their best. You're right, like you're saying. And it was the system that failed that person, even though they were trying their best. And we certainly teach that, and that's how I try to operate when I am involved in safety event investigations. But I don't want to minimize how hard that can be. I think a lot of times it's very human for us to say, it's very easy for us, and part of just human nature, to be like, this person made the mistake, they've got to try harder. But I think when
Right.
you look at some of the literature and the opinions of why healthcare hasn't changed quickly in 25 years since that landmark study, it's that we are so willing to say that people need to try harder. Human vigilance is the answer.
Yeah, be more careful.
Be more careful. You've got to reread this policy, make sure that you get this retraining. We'll put you in through some coaching. And those things
Right.
can be important
Right.
for personal growth. Humans should grow in their roles over time. But it misses those system pieces like you're just talking about that also need to be fixed.
Yeah. I've got some colleagues in healthcare. They share my view. If I made some sort of noise when he talked about, retraining, I kind of try to question, like, well, if the training the first time didn't prevent this situation, I'm not convinced retraining would have maybe anything more than a temporary effect. I mean, this is crude math here, but 2 times 0 equals 0.
Yeah.
And I'm not calling anyone involved a zero, but like when training is, to me, a systemic factor. Just a quick example of, again, something completely unimportant compared to medical error. I remember one time I was at a Starbucks. I ordered a nitro cold brew, which is kind of my favorite beverage, and the barista behind the counter dumped a bunch of ice into it. Now, I did kind of point out, like, gently, like, well, that beverage isn't supposed to have ice. Could you remake that? And then I quickly realized that, she was kind of being shadowed. And I don't know if it was a more experienced barista or somebody was then pointing out, well, see, no, like it was like after the fact, it was like it was training through reacting to mistakes. And I'm like, it didn't, like, I don't know. Like it seemed like that would put the barista, the new employee, through unnecessary stress. Because like you said about your lumbar puncture mistake, it wasn't intentional. She would, and I'm like, oh gosh, take your time and train people. And like, there's probably hundreds of different mistakes a barista could make. Like, I'm jumping to an assumption that the training was completely reacting to mistake based, but
Yeah.
it
reminds me.
I was hoping, like, I hope she didn't get in trouble because it was easy enough to remake a drink. That was, some extra unnecessary cost to Starbucks.
Right. Yeah, absolutely. I mean, no matter what industry you're in, humans are humans, and we're beautifully imperfect, and we have to recognize that. And I worry, and again, I've only ever worked in one industry, but so I don't know how Starbucks or Publix or whatever have you works, what their cultures are. But I just worry that certainly in healthcare that we want everyone to be perfect. And I think that's changing, and I think it's changing for the better, and it allows us to be more mindful about some of those system pieces, and I think that can make more meaningful improvements to how we deliver care.
Yeah. I'm glad you brought up just culture, because that was something I wanted to talk about. And people can go, justculture.org is a great website to learn more about this approach. And, when you were sharing in your story, it wasn't intentional. Like, not to get too sidetracked, but when I was doing, some searches about, stories and journal articles in healthcare, there's this phrase, this word unintended pops up, where they're describing unintended or unintentional medical error. And I'm like, well, they're I think by default unintentional. I mean, it seems like an unnecessary modifier. If it was an intentional mistake, it's not a mistake. It's assault or harm or something criminal. But so I'll get off my soapbox there. But the question back to just culture is, I think it's helpful. There's this framework of like, was somebody intending to cause harm or not, being one of the filters about like what's the fair and just response to something that's gone wrong. What are your thoughts or experiences around that?
I think part of creating just culture, and you're right, there's a lot of great websites where people can learn more about it. I like the videos and the website and the book, really, of Sidney Dekker from I think he's in Griffith University, if I remember correctly. But Dr. Dekker writes a lot about how do you build that idea of justice in your response to error. And the vision, the graphic that I like to think of when creating just culture, is that we don't want a society that is completely blame free, because humans do need to learn and grow. It's part of what makes us feel fulfilled. We want to keep getting better. And so if you make everything blame free, we won't grow. If you make everything blame, the system doesn't change, and people will start to hide mistakes or leave your industry. And so you try to create this like pendulum right in the middle of those two, where you can help others grow, organizations grow, and people grow at the same time. And so I like to think of it as not so much being outcome based in our response. So sometimes I've ordered the wrong medication for somebody and it was caught and no one got hurt, and so we didn't do anything about it because it was caught and it was fixed, and that prevents us from actually exploring why the wrong order went in on the wrong patient in the first place. So we have missed opportunities. Same thing with rule-based responses. A lot of times if we say, oh, well, you broke a rule, so you need to be reprimanded, it also, that one's difficult because it can be sort of controversial, and it's hard to say, yes, break rules, but sometimes rules don't always match what we're doing right at the bedside and policies. And so there needs to be a way to work through those as well. So I like the risk-based approach, where you look at what was the behavior that someone exhibited, and why did they choose to make that behavior? What risk were they choosing to take? And yes, there's some guidance and some algorithms or some writings on malicious action, or someone's impaired. Those individuals need a special sort of approach. I think that is kind of outside of what I think of as just culture. Once you get out of that, though, you're looking at, was this a simple human mistake where they didn't see the risk and didn't choose the action? It was a part of being human. Was it something that they didn't understand the risk they were taking, but it was a behavioral choice, like cutting a corner or doing a workaround? Or was it something that they knew was going to be risky and they chose to do it anyway? And that's more of that reckless behavior. And each one of those has a different response. And really what we should be doing, and this is going to be like Derek Leiner's approach, no matter what you see, I do think people would need support and like psychological first aid. So a lot of times the writings in Just Culture will say that if you see reckless behavior, that's where discipline and punishment can show up. And I don't disagree, but I worry about labeling people. And I think that there's going to be times when I'm trying to be my best self, and yet I still choose a reckless behavior. And I don't want to be labeled as a reckless person. I just, in that moment, because of the surrounding context, made a reckless choice. And so I think if we can remove that label and realize that it was a reckless choice, you still support that person. You can say, hey, because it was reckless, we still need to look at, demerits or reprimands or something, but we want to support you too, because we know you don't try to hurt anybody. So, do you need EAP? Do you need a coach? Those sorts of things, instead of only making it about punishing that person. But I'll get off that soapbox, because I can go on forever about just culture. But
because I mean, there's this point where certainly you punish intentional acts, and like, to me, these are extreme outliers of cases where, again, rare cases where a nurse is intentionally injecting patients who are dying to put them out of their misery. That's, by most laws and most places, considered an intentional criminal act. Then there's, kind of more complicated cases, of like the series, and I had trouble listening to it, the podcast, and then a television series, Dr. Death.
I've heard of it. I don't know I've not heard it, but I have heard of it.
And my understanding of it is, it was a doctor who was known to be performing inappropriate surgeries that were having really bad outcomes. And it seemed like one of those situations where maybe systemically, the organization or organizations maybe kind of looked the other way, which to me, then that becomes a different form of systemic problem. Or, the cases of, well, the organization suspects that somebody's working impaired and doesn't really do anything about it, and then there's a patient harm or death. Like, well, the organization had an opportunity systemically to address that through coaching, addiction treatment, or what have you. I mean, there's I think cases like that are the outlier, as opposed to good people working in a bad system. And I think one other thing that's really informative with the just culture framework is the one part of that algorithm that asks, I think, essentially, would another similar professional in that same situation would they have been pressured to make the same quote unquote bad choice? Because I've seen circumstances where people cut the corner and they get away with it, and those people don't get punished, or they may get celebrated for things they're accomplishing because of or in spite of cutting the corner. But then the one time it bites somebody in the ass, for a lack of a more professional way of saying it, well, then that person gets punished.
Right.
And like we we need to learn from those opportunities, that didn't create harm, and learn early and prevent the big outcome. And like, to me, that's part of what's being fair and just to the people involved. If don't put them in a situation where they are being pressed to cut corners. I'm sorry, I'm climbing up on a soapbox now, but just last point I'll make on this is, I've been in hospitals where, you quite literally go and do an analysis of, like, here are all the tasks a nurse in an inpatient unit is being expected to complete in an hour. And it's like literally 80 minutes worth of work. And so now you're putting the nurse in, I think, a very unfair position of choosing, what can I get away with not doing? And then if it ends up being the quote unquote wrong decision, they might be blamed or punished for what I would say, hey, that screams systemic problem. We've got to reduce waste, and part of that 80 minutes of work is walking up and down the hallway, searching for things. And like, we can improve the process to reduce that 80 minutes down to something manageable, or have the correct staffing level so that people aren't being put in that position. So that's my engineer view of things. What do you say?
I think you're absolutely right. And I love that a lot of the models or decision support tools for using just culture include what you're referring to as the substitution test, because that investigator is really pushed to think about, is there a cultural norm that has led to this happening? And this was just that 1 out of 100 times that it was caught, or something bad happened, rather. And 99 times before it, nothing bad happened. So it really forces the investigator to look through that and try to figure out if there's that system piece that needs to be addressed. Like you said, whether it's the structure, whether it's waste, whether it's movement waste, if things need to be redesigned, if it's staffing models. Everybody is short-staffed these days, so it's hard to really work around if it's a staffing model problem, but we can at least explore that idea. The challenge, I think, becomes who the investigator is. And I think one of the hardest parts about just culture is who is doing the investigating. There are a lot of systems that have leaders as investigators, and I think that they are in a really great position to know what the team what threats are coming at the team, what the team's going through, what the stresses are on the team, what the staffing model was that day. They also carry a psychological size, and so when they're doing a substitution test, there is the risk that they're going to be asking their team members, those they lead, would you do this? And because it's their supervisor or their leader, they'll be like, no, I wouldn't do that. And
Right.
so that maybe introduces a little bit of bias and makes it hard to be fully just in that moment.
Yeah.
The other thing too is if the investigator is the leader who's also responsible for performance evaluations and performance appraisals and the reputation of the service, are they going to really where is their pool going to be? Are they going to be compelled to look more at say it was one person and take the fall for the whole team? Or are they going to be more willing to share more broadly, like, yeah, this is a whole service problem?
Yeah.
And I don't know that. I think there may be people who struggle with that conflict of interest. So I do think that there's value in having peers be investigators of events so that you reduce the psychological size, you reduce the feeling of safety for those who are being not investigated, but interviewed. And I think the substitution test works better when it's a peer.
Yeah. Yeah. And you talk about something that's done 99 times and there's no bad outcome, and then that 100th time it's bad. There's a phrase, I encourage people to Google it because it leads to a lot of interesting reading. The normalization of deviance.
I was just thinking that. Yeah.
That's an interesting phrase. And we're not saying the people are deviants, but it's that, I mean, it could happen in a factory, for an example of, you're supposed to wear your safety glasses. And let's say people get lax on wearing them. The supervisors don't want to rile people up and they start looking the other way. And now you're normalizing that deviance from standard safety practice. And it'll be okay because people wouldn't lose an eye every single day. But you don't know what day it's going to be, and that's why you wear your safety glasses. You're supposed to. So that's an example that could occur in other settings.
Yeah, I've heard it referred to as drift behavior. Also, the spiral of deviance or the circle of deviance. The graphic that I like is that you've got error in the middle, and you've got the safe behaviors on the outside. And every time someone cuts a corner, you get closer and closer to that error. And every time someone cuts a corner and nothing bad happens, everyone adopts that new quote unquote simpler behavior. But of course, at some point, it is going to be risky. And then, of course, at the end of when something happens, it's like, why was no one wearing their goggles? How could you all do this?
Right.
But absolutely. And so that's so important with the substitution test to explore what were the external drivers of behavior.
And then to lighten the mood for a minute, maybe inappropriately, if I were starting a heavy metal band, Circle of Deviance might be a great name, or I would debate Spiral of Deviance. I don't know.
Yeah, I love that. Mine's more of a chemistry nerd approach, but my band name would be the Ketones. Yeah,
that's a good one too. So one other question, and I want to talk about this all day, but I wanted to come back. When you talked about sort of like the feelings and the emotion and the embarrassment, like in Dr. Mayer's story, he witnessed the resident surgeon was the one who made the incision on the wrong side. And that resident surgeon had to go into the corner and sit down because they were distraught. That very human, oh my gosh, what have I done? Reaction. And I'll link to this in the show notes. I really appreciated something you wrote on LinkedIn about your reaction to a mistake. And that was the thing that prompted me to reach out and say, let's do this episode. But I'll encourage people to go read that. But I'm curious, maybe as a final question, what have you learned, or how do you coach others about recovering from a mistake and fighting some of that negative self-talk that is, I think, again, very much human nature, especially among people who care so much about what they do?
I really appreciate that question. I'll take it back just a little bit to try to link just culture into it, because that's how I've sort of developed my approach. We talked a little bit about the different types of human behavior, and I like Sidney Decker's writing where he really pushes people to think of how do you restore people and prevent them from leaving, try to try to avoid people being punished, really focus on people's growth. In that, one of the first questions we always ask when we see someone's made a mistake is, who's hurt? And we, in patient care, patients are our primary victims. We want to make sure that they're taken care of. But the secondary victims can be the people who made the mistake, because we're working in high stakes, high stress environments. We want to make sure we're taking care of the human who's here under our care. And when something bad happens, we can carry a lot of guilt, and we can carry a lot of stress. We can start to have a lot of negative inward thoughts, something that's called the second victim phenomenon, actually. And it's a real thing. It certainly is linked with higher rates of burnout, lower resiliency, leaving medicine, suicidality, making errors in the future. And so it is a problem that we have to address. And I think when you think about how do you help someone work through an event when something's happened, one of the just culture questions is, well, what do the hurt people need? And for those second victims, there is internal work that I think they need to do. And there's external work that the leaders or their peers are obliged to do to help them through it. And so that internal work is what I've been thinking about for a while. And how do you take a step back and grow through that and then get back into the game? And so I have 3 questions or 3 truths that I like to remind myself when I've made a mistake. One of them is, number 1, you're human. Take a step back for a second, go into a quiet space. All right. Number 1, I am human. Humans are always going to be imperfect. I can try my best. I am imperfect. I can't get around that. Number 2 is, okay, I am taking this really hard because I care very much about taking good care of people. And so you need to ground yourself in remembering that we take this job really seriously. And that is something that should be celebrated. And that just having the second victim phenomenon means that you care deeply about the people that you're taking care of. Just to remind yourself, like, okay, I am meant for this, right?
Yeah.
And then number 3 is that you're not your feelings. Like, your imposter syndrome is going to be telling you over and over again, how could you not look at that medication list? Why did you not pull up a computer? It takes 30 seconds. How are you so stupid? Why did you not double check things? And those are feelings. Those are not who you are. And it's very easy to confuse the two. And so if you have a moment to then just ground yourself in those 3 truths. And I like to sort of reflect and retell my story. Some people like to write it down. Some people like to meditate. Some people like to have moments of silence. But if you can reframe the story in a third person and just kind of walk through, I think grounding yourself in the 3 truths and then retelling your story does help you see what the system pieces were. And truly, I think one of the most important things of internal work is to turn it into action. So in my situation, it was describing my, story, telling my story to my trainees, telling my story to my peers so I could hear them repeat it back to me. And I'm so grateful to have been with a group. I still am with a group who's amazing, but even at that time, like a group who was so supportive and were happy to just stop what they're doing and listen to a story when something bad happened.
Yeah.
And then tell that story through the event reporting system. So put it into the system and look for system pieces. Talk with peers about the system pieces. Share with safety event investigators what the system pieces were, what the external drivers were of the event, so that we can make changes. I think once we've done the internal work and repaired and get back into the game, if we don't also report it and talk about where the system can get stronger, that's a huge missed opportunity.
Well, I think that is great advice that I can use when I make a mistake. A software developer who creates some sort of bug, or a company puts out an update that knocks so many computers offline. I hope you weren't having to deal with that very recently. That CrowdStrike problem. A lot of hospitals were, but I think those 3 truths, that framework, I think it's really worth highlighting, and I think something that's a very practical, helpful takeaway. As we wrap up here, I'm just thinking that there's 2 sides of this coin. I interviewed once somebody who wrote a book called, and he knew it was controversial, Patience Comes Second, because he was talking about the connections between, you need to take care of the staff and medical professionals so they can take care of the patients, and this idea of a second second victim. And he talked about all of those things, but attention getting title. But I what I wish, going from soapbox to magic wand, of course, none of us want to see any patient getting hurt. There's debate about the numbers, surveys, studies, estimates, extrapolations, or correct or not. We don't want to see anybody being harmed, and I don't want to see any healthcare professional being harmed emotionally or professionally because they've been put in a situation where an error or harm is possible. And and hopefully we're focusing on things. I know you and I agree on systems, processes, communication, culture. As you were saying, not trying harder, not caring more, not being more careful. I think that's hopefully what we will see someday. It's a tough journey.
It's a tough journey. It's an exciting journey. I know we're learning more every single day on how we can make that more reality. Because you're absolutely right. You're absolutely right. We always do want to take care of patients, and certainly patients first is sort of a mantra of your patient always comes first, no matter what's coming up. But I don't ever want to forget about our human needs too, and what we need to make sure that we are taking great care of patients. People who feel cared for provide the best care. So,
absolutely.
We have to do the work to make our organization and our models for healthcare delivery stronger, I think.
Well, Derek, thank you so much for being a guest, for sharing your story. Thank you for the work that you're doing out there to improve things in healthcare for your patients, for your colleagues, and really appreciate you being able to have the conversation here today. Thanks so much.
Well, thank you so much. Really enjoyed the conversation.
Thanks.